Labes Ritas. First of all, thank you to Professor Chaplin-Schatz for inviting me and to speak with you here about what has changed in HIV in the past 30 years. Probably a task that I may not for everybody be able to commit perfectly, because explaining in 30 minutes what has happened in 30 years is almost an impossible task. So I picked and choose some of the most important things, and well, if there are questions on topics that I didn't raise, we can always see in the question time or in the break, because I will be here the whole day. So, who am I? My name is Els Hollanders, and since 6.5 years I work as a full-time employee for VIV Healthcare. But in fact, I'm working already more than 20 years in HIV. It's my passion, and so that's probably, for me, the easiest link with speaking about 30 years and what has changed since I was fortunate to spend 20 years in HIV, and I must say, yes, indeed, a lot has changed. So just to tell you what is VIV Healthcare, because VIV Healthcare as a name may not exist very well maybe in your heads, and that is because in Lithuania we work together with GSK, but in fact it's a pharma company who is 100% dedicated on HIV, and so we collaborate here with GSK. But the rest of my talk will not at all be about a pharma company or about drugs, but will be focused on what has changed. And in fact, it all started in 1981 when we had the first cases of a rare pneumonia seen in some gay men in the United States in LA. And the picture has changed completely, because I don't know, if you would ask people in the street who are the ones who are living with HIV and AIDS, I think still a lot of people may think about just the gay man. But some years thereafter, in fact in 2002, the whole epidemic has changed so much, and still today it's like that of everybody who is infected, 50% are women. So that picture has changed dramatically, going from pure a few gay people to 50% men, 50% women. It took several years to find out who is the cause of HIV infection, called the HIV virus. Both have received the name for a very easy reason. It can be found in human, that's the age, and it changes the immunodeficiency, so it is HIV called both for the infection as for the virus. So in the beginning it was seen as a bit something strange, what is happening there in that gay man, but bit by bit the disease came more into the public, because then also suddenly some famous actors and rock stars, and you have seen also some pictures from Professor Chaplin-Schatz with the singer from Queen who also died from AIDS. But still, and I will touch a bit on that later too, the stigma and the discrimination has not much changed over the past 30 years. Still a lot of people don't dare even to kiss somebody with HIV because they think it will transmit HIV. There have been changes, like the professor also showed too, on drug treatment. I will give a bit more explanation on that too. But a lot has also changed from the government levels, politician levels, because if you have now today still an epidemic, it means that also on local level, international level, you have to do something on the political level, on funding, money, to beat the disease. So these are recent data that came out. In fact, we have two international organizations, UNAIDS and WHO, who look very well into the data and who estimate what the incidence is and what the number of people are today living with HIV, how many are under treatment. And in many countries, unfortunately, they still need to be estimated because there is no official register for HIV infections in the country. So today there are 37 million people infected with HIV, and there is still every year about 2 million that is added. So we are still having an epidemic, but we hope soon to change it. So in fact, one of the big things that was announced in 2000, as you all know, the Millennium, and they called it the Millennium Development Goals, is that we had to try to change drastically the curve of the amount of new infections, but also the amount of people dying, but also try to increase the number of people who are treated. And you see it in very bright colors here on the slide, is that around 2000 it was really shocking. You still only had 1 million people who got treatment, while in 2000 you had already 30 million people who were infected with HIV. So the Millennium Goals said we have to try by 2015, and the two last numbers are related to that. We have to try to get 15 million people on treatment. And have we succeeded? Yes, we have. So a bit of relief, but you know, 37 million today, we are not yet there. There's still a gap that we need to close. And so they are now trying to close that gap, because by 2030, they would like that everybody who is infected with HIV gets a treatment. Now, the number is growing, and a bit growing, but on the other hand, not growing as fast as you may imagine, because still a lot of people are dying. But also on the new infections, we aim to reduce the number of new infections, going from what now, for example, 2015 was again worldwide plus 2 million, is to hope that by 2030 this would only be 200,000. Which is still not saying, okay, we have stopped all transmissions, but at least we could say it's not anymore an epidemic. So here on the slide, you see the curve, because you may say, oh, it's a bit in logic, not so logic what she's saying, because in 2000 you have a bit more than 30 million, and today 37 million, so it hasn't grown so much. But if these Millennium Goals would not have been started, you can see here, then the blue line would have gone up very much. So treating the patient, but also prevention, has changed the curve. In fact, 30 million new infections have been kept safe, which means at least all the activities have helped. And also on the level of children, we have been able to reduce the number of infections, not so much because children got treatment, because this has only changed in the past years, but more because over the years after 2000, more pregnant women were treated. And unfortunately, there are still countries in the world, it's a bit shocking, where pregnant women are still not tested on HIV or don't get treatment. So there's still improvement that can be made. So at the end of 2014, UNAIDS wanted to give a global message that we have to change these numbers, and they started to speak about 90-90-90. I'm sure that several of you may have heard about it, and it stands for very simple messages. In fact, the first 90 means that for everybody who is living with HIV, 90% of them would be diagnosed. The second step is, of all those who are diagnosed, 90% should get a treatment. And the third step is, if 90% of those who are treated should get an undetectable viral load. And that is very important, because it leads to the chance of living longer, but also not to contract any opportunistic infections or cancer, but also it lowers the risk to transmit the disease. So soon thereafter, they gave themselves even more challenging numbers and tried to speak about 95, 95, 95. So again, the same meaning of the numbers, but even a harder target, more difficult to reach. And another factor that is very important, and I mentioned it already, is discrimination. There are still today people who can't get treatment because, oh, you are gay, you are a drug user, you are a migrant, you are a sex worker. There are a lot of key stakeholder populations who are excluded from standard service, like what you could say a regular HIV patient. And that is also something they would like to reach, that there is no more discrimination of people living with HIV in the world. So at the beginning of this month, there was a high-level meeting organized by the United Nations, and there a lot of representatives from all over the world, 193 member states, have signed a political declaration in which they commit to try to get these targets. But not only to commit to these targets, but also to additionally commit to the 90-90-90, because, okay, from 2000 to 2015, we have been able to treat 50 million, but 2020, that is the year where we have to reach 90-90-90, that's not so far away. It's a good 4 years, and the goal is that by then we need to treat 30 million. So we were able to treat 15 million in 15 years. Now we will have to do a huge acceleration of treating another 15 million in less than 4 years. So that's why it was discussed, and that it was asked that everybody in the world would stand together. But again, they added some additional things. They said, well, getting that number of new infections of 2 million a year lower, we have to get it down very drastically, and we have to get it down to fewer than 500,000 people newly infected. So that's, again, going to 1/4 less than they thought already at the end of 2014, also to reduce the number of people dying and eliminating the HIV-related discrimination. So, just explaining what that 90-90-90 is, to give a bit more clearer picture. As you can see, so we have these 37 millions, and if you apply that 90-90-90 rule, it would mean these three different numbers, as you can see in the orange, the light yellow green, and the dark green. So that is what we want to reach. And is it difficult? Yes, it is, because I'm going to show you how it looks today. That is how it looks today. So we are not yet there. And especially if I can then play, like with the slides, if you go back and again to this one, you see how much we need to do to reach that target. So the first 90 was about testing the people who may have contracted HIV in their life. And I just would like to focus a little bit on what is happening in Europe, because, of course, it's a little bit closer to Lithuania than to speak about the world. We have since 2013 an organization, HIV in Europe, who is really contributing to improve testing. They also organize testing weeks, with that, which I will show you. But here on the top right, and I really would invite you to go to this site, you have a sheet which is called HIV clinical conditions. And what does that mean? In fact, a few years ago, they have found that about 10 diseases which can be found very easily by a GP, so when they see patients on a daily basis, if the doctor would see any of these 10 diseases with a patient, there should be like an automatic lamp burning in his or her brain and say, okay, I have to do an HIV test. Well, as of this week, and I'm proud because we are supporting this too, these sheets and this material can be found in all languages that are spoken in the European Union, also in Lithuanian. So we really hope that that simple sheet, it's just one page, may accelerate GPs also to perform the test in case somebody has a disease. I can give an example. For example, having a herpes zoster, having like really the symptoms on the back of a very young patient, like a 20-year-old, this is not so usual. Well, if a GP sees this, they should think about doing an HIV test, because there might be a big chance that the person also has HIV. So the testing week is something that is promoted. It's happening in the week before World AIDS Day. World AIDS Day, it's a standard day, December 1st. And this is really to stimulate all the patient organizations, NGOs, hospitals, governments, whoever in the world, to focus attention during 1 week to improve HIV testing. So if you would like to find out, I would simply say Google it, Testing Week HIV, and you find all kind of information how you can be involved, how you can understand how testing should be done, and there are a lot of stories of patients and organizations who tell how they have done this in the past years. The new dates have just been announced officially last week. It's from 18 to 25 November. So the ECDC, which is the European partner of, let's say, the worldwide well-known CDC, has also since some years actively contributed to look into the numbers of HIV infected, the causes, the diagnosis, the transmission rates, and so on. And so because many of the countries, even in Europe, don't have an HIV registry, they just have to guess how many people would live with HIV. And at the end of last year, they have created a modeling tool, so you can simply download it from the ECDC website, and this helps everybody in Europe simply to calculate the number of people who would be infected in the country. And I think that is very useful because, for example, if the tool would tell you there must be 10,000 HIV infected in your country and you only are aware about 1,000, it means you have to find these 9,000 others. It's also good for countries where they have already, like I'm from Belgium, they have a registry since '86, so they followed up very closely, but still they can trigger themselves to see, have I followed it up, how is it matching with the modeling tool. The first 90 was about testing. I'm now going into the second 90, which is treatment. And this is a picture of what has become available of HIV drugs. And it doesn't matter that the letters are small, but it just shows that since '96 there have been about 25 drugs available, made available for treatment. And in '96, I call it myself a little bit like the Big Bang, because that was the first year where they really could say to the patients, now we have a very efficacious combination for you. They call it HAART, which is highly active antiretroviral treatment, because it was composed of 3 drugs, and that is still the formula, the magic formula of today. You must normally give 3 drugs to have an efficacious treatment. Now with the new formulations, they have been able to put 3 drugs into 1 pill, and that's why today we can treat with 1 pill once a day. But it's not because all these pills are now available that people have been treated as such. In fact, it's again because UNAIDS and WHO said we have to do something about all these HIV infected people, because if they live without treatment they will die very quickly, but they can also transmit the disease, certainly when they don't protect themselves. So the first big bang to treat more patients was done because they announced to treat 3 by 5, which means in the beginning of 2000 they announced we would like to reach that 3 million people are treated by 2005. And then bit by bit, years after years, they set new targets. Like for example, in 2006 they said, well, we need to achieve universal access for treatment by 2010. And it was reached in 2009. And then Professor Chaplinskas spoke about the CD4. So some countries limited themselves and they say, oh no, we will only treat when the CD4 is below 200, which is already a very bad stage for the patients. Then some countries said, okay, we will start soon, we will do it when the CD4 is below 350. But if we continue to look today, in fact, we should not look anymore at the CD4. Today we have evolved as such that whatever the CD4 is, patients should be treated. And that is because there is scientific proof for it. In fact, last year, a very big scientific study, which is called START, has shown that even if you have patients who have a CD4 above 500, that still immediately starting treatment for them lowers the risk to contract other diseases like opportunistic infections, cancers, and even lowers the risk of death. And of course, this has given the opportunity of WHO to again change the approach of what the guidelines should be of treating, and they changed in order to say now everybody who has HIV should be treated. Now I can already understand, and I don't know if there are any government people or politicians in the room, but people can of course say, yes, but okay, treat 50 million, then treat 30 million. Who will pay for this? Yes, treatment costs, doctor consultation costs money, hospitalization costs money. Well, the UNAIDS has calculated this, and they have seen, taking into account all the doctor visits, hospitalizations, eventually treatments for opportunistic infections, that if you would invest today $1, that you will have a return on investment of $17. So this is food for thought, certainly for countries who have to think about investment in treatment. I can understand a politician today has only a budget and says, well, I can only spend this, and maybe this person is not anymore in his or her function when the $17 return. But it has been proven, and the UNAIDS has made a very interesting brochure on that investment today leads to an earning in the future. So 2 weeks ago, WHO issued new updated guidelines. I think very important, because also for under-resourced countries, it really acknowledged the fact that everybody should be treated, children, pregnant women, key stakeholders. And also, what is very important, they speak about prevention. I will touch a word on that too. Now again, we are not the world here, we are in Lithuania. So for Europe, we have the European guidelines, and I have seen in the program that Professor Horben from Poland will speak about the EX guidelines. But even the EX guidelines, who are, if I may say, today, in fact, a bit stricter in treatment and in prevention than the WHO guidelines, which is a world of difference, because a few years ago, EX was more active and more broader in treating and prevention. So World AIDS Organization really made a difference. We can say that in the European Union, several countries are not even applying all the EX guidelines rules. So we need to have a change there too. Treatment is not easy. There is treatment, but like in '96, when we really started more and more to treat patients, there were the difficulty, and Professor Czaplinska showed that clearly in some pictures, that sometimes you had to slow more than 30 pills. Now today you can do it with one pill, but there is still issues that can pop up, and that's why a very good doctor-patient relationship is necessary. We have to minimize toxicity, improve efficacy, minimize drug interactions, because the HIV drugs can also be taken with other drugs, and now there is a new fashion in Europe of taking recreational drugs, which in fact have influence on the sexual behavior of people and can lead to very nasty drug interactions, even bring people to coma. So also for the doctors, they are challenged, let's say, every day to see how they should treat patients in the best possibility. So I said prevention is important, and I know prevention and PrEP, I will briefly touch on it, is sometimes not yet possible in every country. But there is another very important study that came out already in 2011 that showed that if you treat HIV-infected people today, then the treatment on itself is also a good, helpful tool in prevention. Because in the study they saw that it reduced the HIV transmission to HIV negative partners with 96%, which is very high. So shortly thereafter, and again WHO has it already in their guidelines, there's the big message of PrEP, which means taking prevention even before you would be HIV infected. So the R is a bit different than the PEP, but that again will evolve, I'm sure. So first in the US they have already PrEP, in France they have it, Canada, Australia, and a little bit in Belgium, but some countries like in the UK, they tried now already 2 times with the NIH to get the PrEP, and it was refused. Treatment, okay, yes, but you still live until you die, unfortunately, with HIV. There is no cure, because the treatment, in fact, lowers the replication of the virus as much as possible, but can't stop it 100%. So there's a lot of activities, programs, budgets made available to try to find a cure. I could speak a week already about all the trials ongoing, but I will not bother you with that. Quickly, children. Children have been forgotten a bit. This is a nice pictogram from UNAIDS 2013 with shocking numbers. Still today, 200,000 children get infected every year. 200,000. So a few weeks ago, a new fast-track program was launched where they would like to try to stop AIDS in children, adolescents, and young women. Now, I spoke a little bit about some vulnerable stakeholders which are not in every country treated or get tested or are even excluded from society because of stigma and discrimination. And I just listed them. I think everybody can understand why somebody would discriminate them, but it's in fact, from my view, ridiculous. They should get the same treatment as every other HIV patient. So migrants, prisoners, IVDUs, sex workers, MSM, and transgender. So one of the last slides, stigma and discrimination. As I said, some people, when they announce that they are HIV, suddenly they can't get in touch with their friends anymore, or their family says, go away. For example, mothers, especially African mothers, can be excluded from the family because it's a tradition that you should breastfeed your child. So you can't do that because HIV can also be found in breast milk. But what is happening then, these women, when they don't breastfeed, they don't want to do it because they don't want to make their child also infected with HIV. Well, in the cultures of many African countries, these women will also be sent out of the family because they are not breastfeeding their child. So it's a very complex thing, but I think everybody is intelligent enough to do something so that we would not have stigma and discrimination. So since about 3-4 years, we have also in March our Zero Discrimination Day. But as I told you before, we really would like worldwide that by 2020 there is no more discrimination of HIV-infected people in the world. So I would like to stop here. Achoo, I need to say. So thank you, and when the question time is there, I'm happy to answer your questions.